Okay, well, welcome to another MedCram lecture. We're going to continue our talk about heart failure. One of the things I wanted to review was the first lecture is the difference between systolic and diastolic dysfunction. Basically, systolic dysfunction is where the heart is just not contracting well enough and blood cannot make it out of the heart. As a result of that, blood won't enter the heart because there's still blood in the heart. This is as opposed to diastolic failure. In diastolic failure, blood can't come into the heart because this ventricle is too thick. And as a result of that, if blood cannot come into the heart, there's no blood for it to pump out. And that's the cause for congestive heart failure in both of those cases. What I wanted to emphasize a little bit here is the difference between the right side and the left side. If you've got heart failure predominantly on the left side, then you're going to have backup from the left ventricle into the left atrium and then finally into the lungs, which is going to cause pulmonary edema and pleural effusions. Please see the lecture on pleural effusions. The problem here on the right side is you're going to have backup into the right atrium, and then from there you'll have backup into the vena cava, and then into the lower extremities, which is the most dependent portion of the body. Here's the thing. If you have left heart failure, that left heart failure could go into the left atrium, then go into the lungs, causing pulmonary hypertension. Depends on how long it's there. If it's there for a while, you can get actually pulmonary artery remodeling, which will cause permanent pulmonary hypertension. And then it'll come all the way back here, and the right ventricle will then start to be elevated in pressure, and then the right atrium will be elevated in pressure, and then finally the vena cava will be elevated in pressure, and that will go down and cause lower extremity swelling, which is one of the symptoms and signs of congestive heart failure. If you just have right heart failure, and that can happen for a number of reasons, sometimes there's diseases in the lungs like pulmonary fibrosis, like idiopathic pulmonary fibrosis, like idiopathic pulmonary hypertension, sarcoidosis. There's a number of things that can happen just in the lungs, and all you'll see is right heart failure by itself, and then things back up and go into the body. But the left ventricle in that case would be normal. Okay? Sometimes you can see mitral stenosis and it will back up. Anyway, you could do a number of exercises, but you've got to know what the order of the circulation is. And just as an overview, let's go through some just real quick examples here. If you had systemic hypertension, so in other words, in the aorta, you had high blood pressure, okay? That means that there would be a lot of pressure being put here on the left ventricle. We're going to talk about this. This is afterload. So the pressure in the aorta is going to be very high. That's going to put stress on this left ventricle. And after a long period of time, this muscle is going to get very thick. And as a result of that, you're not going to have the ability for this ventricle to relax. And as a result of that, the blood will not be able to get into the left ventricle. And as a result of that, the pressure in the left atrium will go up and eventually go to the lungs, which will cause pulmonary hypertension. Okay. Another example would be if the valve here was stenotic. That would also cause the left ventricle to hypertrophy, and you would get the same situation. Now, this is opposed to ischemic heart disease, where you actually have a blood vessel that feeds this area, okay? Feeds this area with oxygen, and if for some reason you've got a problem with this blood vessel, which comes off the aorta, actually, and feeds this area, or any area of the heart, but particularly here the left ventricle, and if there's not enough blood getting to the muscle of this left ventricle, it will die. And when it dies, you have a heart attack, and this left ventricle cannot contract. As a result of that, you're going to get systolic dysfunction, which means the heart muscle is not going to be able to pump out through here. The cardiac output will reduce, and as a result of that, the blood will not be pumped out, therefore not as much blood will then be able to enter the left ventricle, and as a result of that, you will get congestive heart failure. There are still other diseases called cardiomyopathies which affect the entire muscle of the heart, and these are things like restrictive cardiomyopathy or dilated cardiomyopathy, or hypertrophic cardiomyopathy. And depending on which one you have, again, you'll have different pathophysiology. For instance, if you have hypertrophic cardiomyopathy, you just have a very thickened heart muscle. And as a result of that, you're going to get diastolic dysfunction. Sometimes you can have a dilated cardiomyopathy. That means it becomes very large, but very thin-walled. And as a result of that, you can't pump. That could be caused by alcohol. That could be caused by a virus like Coxsackie-B virus or enteroviruses. So there's a number of different types of causes for cardiomyopathies. Okay, so let's clear the page a little bit and let's talk about some terms that you're going to need to know if you want to talk about the pathophysiology of heart failure. The first thing I want to talk about is this term that you might hear about, and it's called preload. Okay? Preload, if you can imagine, if you are winding up to throw a pitch. Okay? If you're winding up to throw a pitch, it's how much you pull back. So in terms of the heart, you know that the heart is going to contract. Well, when blood comes from the right atrium into the right ventricle, and similarly from the left atrium into the left ventricle, the right atrium and the left atrium are going to contract and push that blood down into the ventricle. And what you'll have is a nice big ventricle at that moment. Okay? So that's right before systole. These ventricles will be very big and full with blood. Now, what does that do? If you can imagine, you have these sarcomeres. Imagine this from physiology. And you have the troponin and the actin and the myosin and all that sort of things going on. These are what the sarcomeres look like. And they've got little connections here, if you look microscopically. And these are the things that cause actual motion. Locomotion, okay? So this is what actually allows you to move. What's going on in preload is these things are being stretched, okay? So that they can actually contract. And you'll notice that there's a relationship that occurs in preload, okay? If we put preload here, so basically what's preload? Preload is how big is the ventricle right before it contracts. We call this the end diastolic volume, okay? End diastolic volume. How big is the ventricle? How much blood is in there right before it's about to contract? So preload's on the x-axis, and let's say we have stroke, work, or wall tension on the y-axis. In other words, this is how much work it can do. If this is what we have, you can imagine that as preload goes up, the stroke work is also going to go up. It almost looks like a hemoglobin binding curve, but it's not quite. And you can imagine that there's a point upon which if you stretch something so much, you're not going to get anything more out of it. And that's kind of the way it goes. Now, in a situation where you're not filling up the ventricle as much, your stroke volume or your stroke work is going to become less. But if you can fill up that ventricle with more blood, the stroke work that you're going to get out of that ventricle is going to be higher. That's the issue with preload. So this is what you need to know about preload. As the preload goes up, the tension goes up. What are some things that can increase preload? Things that increase preload is total blood volume. What are some other things that will increase preload? Well, actually, high venous return. So what's high venous return? The more blood coming back to the heart is going to increase your preload. So what would that do? Things like supine position. Okay? Putting the head down. Putting the legs up. All of those sorts of things. The other thing that you need to think about, big time, is atrial contraction. So the thing about atrial contraction is when the atria contract, they are pushing blood from the top part of the heart down into the ventricle part. And that little, what we call atrial kick, is going to make that ventricle bigger right before it contracts. So atrial contraction is one of the big things involved with preload. And that's important because if you have something called atrial fibrillation, guess what? You're not going to have preload or as much. So atrial fibrillation diminishes your preload. And that's why when people go, sometimes people go into atrial fibrillation and they don't tolerate very well. Let me give you an example. Imagine somebody has hypertension, okay? And so they've got a very thick left ventricle. And so blood does not want to come into there very well. Let's say they've got an atrium up here that the heart is depending on that atria to kick that blood into this very non-compliant ventricle. And then all of a sudden, as a result, this goes into atrial fibrillation. You can imagine that you've just lost that atrial kick to get that blood into that very non-compliant ventricle. As a result of that, your cardiac output is going to drop tremendously, and that means that your blood pressure could go down. So you have these patients with diastolic heart failure who do not tolerate atrial fibrillation very well. So far I've talked about preload being something that is very good. If you have preload, that means your heart's going to get a lot of stretching, and that means it's going to be able to contract out a lot of blood. That's great. Now the problem is though, is if you've got systolic heart failure, you can also see here, or even diastolic heart failure, you can see if either blood can't get in or blood is not being pumped out, there's going to be a lot of pressure back here, and that can also cause an increase in preload. The other thing you've got to realize is this, is here's a diagram of the heart muscle, okay? As you may know, the heart muscle is supplied by epicardial vessels, which then perfuse from the outside in. And then when they're done, they get picked up by the veins. Okay? And you know where those veins dump into? They dump into the coronary sinus. And that coronary sinus dumps into the right atrium, which is directly related to the preload. Now, this may seem a little weird. So let's follow this. So blood is going from the coronary artery into the muscle. It gives off its oxygen, and then is picked up by the veins and gets dumped into the right atrium. Here's the problem. If the preload in the right atrium is very high, that means the right atrial pressure is going to be high. That means the venous pressure is going to be high. And we know that the flow in these vessels is going to be dependent on the difference in the pressure in the artery minus the pressure in the vein. If the pressure in the vein is high, the flow is going to be low. So in these situations where you want to increase coronary artery flow, you may actually want to decrease preload. Now, where would you see that? You would see that in congestive heart failure. Guess what nitrates do? Nitrates actually drop preload and something called afterload, which we're going to talk about. But they actually drop preload more. And that's actually the primary mechanism by how they increase coronary artery flow, is by dropping the preload in the other direction. It actually increases the flow to the myocardium when it's ischemic. Okay, so that's preload. Let's talk about afterload next. Please join us for the next lecture.